Next session is the much awaited interview with Professors Tim Briggs and Deborah Eastwood. And I'll be asking the esteemed leaders questions that have been by trainees.
Is that the first question?
I'll just ask this mic Barrett to pause. Yeah, thank you. So at the end of the interview, we'll have questions from the participants, if that's all right. And if there's any that the participants would like to ask, please just put them on the chat during the interview. Just to introduce Professor Briggs, Prof. Briggs led the GIRFT Getting It Right First Time nationwide study when he was president of the British Orthopaedic Association. The methodology that was first conceived and developed by Prof. Briggs to review elective surgery to address a range of observed and undesirable variations in orthopedics is now applied across 40 surgical and medical specialties. He has been working as a consultant orthopedic surgeon at the Royal National Orthopaedic Hospital since 1992. In September 2015, he was appointed as National Director for Clinical Quality and Efficiency for the NHS. He was made a Commander of the Most Excellent Order of the British Empire in 2018 New Year's Honours List for services to the surgical profession.
Hi everyone, I would like to introduce to you Professor Deborah Eastwood. Prof. Eastwood is a world-renowned paediatric orthopedic surgeon working at Great Ormond Street Hospital in London and the Royal National Orthopaedic Hospital in Stanmore. Of her many leadership highlights, some of them include serving as past president of the European Paediatric Orthopaedic Society, being vice president-elect of the British Orthopaedic Association, and former council member of BISCOS, or the British Society for Children's Orthopaedic Surgery. She has also been a clinical director at the RNOH, and she's an active member of the Paediatric Orthopaedic think tank, IPOT.
Professors Tim Briggs and Professor Deborah Eastwood, thank you once again for joining us in the Learn to Lead series. We've organised the session into 4 parts. The first is driving change. The second is dealing with problems and failure. The third is leadership characteristics and styles. And finally, questions and answers from the audience.
So if we dive straight into the first section on driving change, Professor Briggs, could I ask you, over time, you have been incredibly successful at driving change. What lessons have you learned about driving change that you think would be useful for us trainees?
I think Professor Briggs has been removed from the panel.
Demoted. We'll get Carla to.
Carla, Professor Briggs, could I ask you to raise your hand if that's all right, and then we'll add you back.
Whilst he's been promoted, Sunny, do you want to know? Is it Pam? Do you want to ask Professor Eastwood a question?
Yeah,
yes.
I'll ask Professor Eastwood next question if that's all right. So, what could adult orthopedic leaders learn from pediatric orthopedic leaders and vice versa?
I think my buzzword when I was going through some of the ideas that you asked me to consider about leadership was that I like to use the word engagement and involvement, and I think that's the most important thing that I do in pediatric practice. If I'm having a consultation, I really do have to involve the whole family and the therapists and the great-grandmothers in the discussion. And I have to use really simple language to be effective in my communication skills. And I don't think those are inherently different from what adult orthopedic surgeons do, but I think it is qualitatively a little different. And so I think some of that is what I feel we should be doing as leaders, and finding some way to engage and communicate with all our membership, for example, rather than just the some who are willing, the few who are willing to be engaged. So I think that would be perhaps one of my turning key points.
Okay, thank you.
Should we? Do you want to carry on with? Shall we carry on with questions to Prof. Eastwood for the moment?
Yeah, let's do that while we try and
The other
find
factor
out.
I was going to say there to your question is that I think it's also because you're involving a wider group than just the patient in front of you. And I think that's another key that pediatric people perhaps do differently from adults. They're much more prepared to engage with a broader audience in order to bring you along.
Okay. I think the next section is really about dealing with problems and failure as well, and I think that's quite key for all of our trainees to understand, and as they will be dealing with it in the future. How do you deal with things not developing or going according to plan and not meeting your expectations?
Well, I either get very upset and hurt that I haven't got my message across, or I reflect and decide that my message was pretty pathetic in the first place, and that's why I haven't got people to come with me. Or else I reflect and think that my message is still good, but I have not got it across well. So I think that's what I've learned is not, I don't want to get a reputation for saying, you will eventually see it my way and I'll just keep representing the idea until you understand what I mean. But I think there's an element to repackaging the idea and reselling the idea, but also listening and really hearing why it was that it didn't work in the first place. So that's, I think, some of the key points.
Okay. What about, yeah, go on, sorry, Pam.
Yeah, I was just one of the other questions we had for you on the sort of the same umbrella was about the biggest challenges that come with being a clinical director or acting up as a clinical director. Yeah.
So I think that totally highlights how even when you're lucky enough, as I am, to work in a unit that's a friendly family, we bicker from time to time, but we don't fall out particularly. So I work within a friendly unit who you think it would be easy to take them along with your ideas. And then you find that what I thought was a simple little thing that we should do to be more effective, more efficient, more whatever it was, more doing what the management wanted us to do. And they suddenly say, oh, no, not even if you ask nicely, am I doing that? So it's just, again, an understanding that you think you know people well and you think you're all going along the same path, but not always, or else you're taking them a step too far. So maybe you have to go back a couple of steps and say, okay, where's your comfort zone? Let's go back to your comfort zone. And then wouldn't you just like to move that a little bit, come with me in this direction a little bit? Or the classic, try and make them come up with the idea and then say, oh, that's a brilliant idea. I think we should do that. The fact that it was just like my idea or the management's idea. So staying friends. Staying friends is one of the key ways of dealing with disappointment and struggles within a department, I have to say. But I think a recognition that it is disappointing, because we wouldn't do the leadership roles if we didn't think that, this is going to sound arrogant because I don't consider myself a good leader, but you assume that you've got some skills and that you're liked by your colleagues, and therefore they will do what you want them to do, but they won't always, and that's again, disappointing and hurtful sometimes. So dust yourself up.
So that fits in nicely to the next section that we were going to bring you on to, which is about leadership characteristics and styles. And in previous interviews, you've talked about the importance of delivering holistic orthopedic care. And so what do you think are the key characteristics of a holistic leader, and why are they so important to you? You've mentioned them in 2 podcasts I've listened to, and you're very passionate about it.
So I'm obviously, you catch me out, or they caught me out, and I had no idea. And all I could remember was I've not read a management book in my life. All these people who put their slide up of, I've read this book and this book is very motivational. I haven't done any of those. And I have Googled leadership styles, and I don't seem to really fit into any of those, and I haven't got a plan. All I can say is that I'm different from other people. So I think Tim and I, for example, no one would say we were truly similar, but we are similarly passionate about what we do. And I think overall we do it in similar ways. But what I mean by holistic is that you've just got to accept that the sum of the parts are greater than the individual whole. So you've got to really make the most of everyone's contributions to the team and make sure that they're valued and included, rather than have it a top-led process. So I think we've got to include everyone and accept that by including everyone, we will get a better outcome. So that's essentially what I mean, I hope.
So we need an inclusive leader and avoid living in an echo chamber.
Yes, absolutely, absolutely.
You've previously been voted Trainer of the Year in the Ports rotation, which is a fantastic accolade. What makes an effective leader of a surgical team?
Oh, I think making it fun, and again, in being inclusive of all members of the team, but also engaging them. So within reason, the more people who are scrubbed up and the more people are holding retractors, the happier I am. Obviously, there are limits, and I don't want people scrubbed up for no reason. So if you're going to have them scrubbed up, they've got to feel engaged, and they've got to feel that their bit of the surgery that they do, even if it's only holding the retractor, is the key to the procedure. And then I like people to, I hope no one is listening that shouldn't be listening, but learn a little bit by their mistakes. So I like to be able to give them a little bit of leeway in doing the operation, and I never let them do something wrong, but I will let them just find something a little bit difficult until they learn. And they learn pretty quick in my theatre that they have to ask why it is that it's a little bit difficult. And usually it's just because you're not using your assistance a little bit hard as effectively as you should. So I think we have to have a team who understands the patient, understands the problem and the pathology, and that we're all in it together to get the best outcome. And then everyone plays their role in the team, and everyone comes out at the end of the list feeling they have done something more than just assist. Assisting is really important, but that they've actually, yeah, well, assisting is hugely important. To do assisting well is a really good skill. And so that's why some of the juniors, when they've had a bad assistant, or when I'm deliberately not assisting them very well, then they have to ask, would you please stop gossiping, Ms. Eastwood, and would you please pull in the right direction? So yeah, trying to make everyone feel involved and part of the team. And so it worked. I bribed a few people along the way. Maybe that helps as well.
So in summary, you feel that creating a welcoming, inclusive environment in your theatre has served you well?
Yeah, it has. It has. And I need people to be trained, and I need them to practice their craft in my theatre, because I don't want them to practice their craft as a consultant without having practiced before, if you see what I mean. So I need them to be happy that they know how to ask for help when they need it, how to feel confident when things are going wrong, meaning not arrogantly confident, but the confidence to accept, okay, this isn't quite right, so let me just work out what I do next. So I've talked more about surgery than leadership there, haven't I? So obviously that's my main passion, surgery.
Well, I'm sure, you know, all of us who have attended today feel the same way. We love surgery, and we would love to be great leaders in the future.
Yeah, yeah. So if we want to change things, you have to do it by leadership, which I never thought I'd be someone to say that. But if I want the best for my patients, I'm going to have to now, or one has to help bring about change. And nothing has shown us that more than this COVID period. You know, the amount of change that the NHS has undergone is truly unbelievably exciting, and we just have to make sure that we harness and keep some of those bits of change. Otherwise we're sadly back to the same old, and that really would be a tragedy.
Sorry, Professor Eastwood, I've missed Prof. Briggs has just called, and he's having trouble logging in, so he should be with us very shortly as well. I've got a question, if that's all right. So can I ask you what your particular leadership style is, and what kind of advantages, disadvantages might come with it?
Again, I fear I'm getting repetitive, but I need people to be engaged, and I need to help them engage. Mm-hmm. So the really bad news from my point of view today is that we just finished our elections for the trustee positions in the BOA, and we only got 20% of people to vote. That's better than it was, but last year when we had a pandemic, we had a 40% response rate. So obviously this year people are uninterested or too busy to click on the link in an email and vote for the people they want to represent them. So that we've still got great people, great people applied and great people have been elected. And I don't really care at one level, but I do care hugely that we have not managed to engage our association well enough that they won't, vote for their potential leadership positions. So I think it's just people are really hectic and really busy, but that's something that we need to change. And I think that won't change, so it may not change by me being critical. And I'm not critical. I want to know why it was that we failed to do that, because unless we can engage our association members, then we're not going to make as much progress as we want. I do not want it to be seen that we wouldn't vote because we don't think it'll make a scrap of difference, that the bigwigs of the BOA are just going to carry on doing what they want to do without any reference to us. That would be a real tragedy. So if that is at all a perception, then that's what we need to change. And so I hope by engagement with our members, we will be able to change that.
Okay, thank you. Any further questions from the audience? We're just seeing if we can get any questions from the audience themselves.
Thank you, Prof. Eastwood. I've got a question. So what are your outside interests that help you get through the day?
Work. I do work and work. So that help me get through the day. I think what helps me get through the day, Neil, is knowing that I care about the job I do and that I care about my patients. And I do switch off when I go home, but I don't switch off completely. So you could say that's a criticism, but actually it's the way I am, that work is a part of me. So I don't particularly look forward to going home to switch off from work. It's part of me, and I know one should have a work-life balance, and I probably haven't got that, but it will never be a perfect balance, and it's always going to go up and down in sync. So I don't mind about that. But then it's nice to be distracted by life in general. So, my hobbies of eating and drinking and chatting to friends and everything, that's never going to change, nor am I going to get tired of living in London and enjoying all that London's got to offer.
So you're a social butterfly, and it's those interactions that keep you going, I guess, is perhaps the
Yes.
Because for example, I think I've seen a few pictures of you in the media at Lords.
Oh, yes.
So cricket is a passion of yours, and sports is synonymous with orthopedic surgeons. You're a jock.
Yes. So calling me a sports fan is better than calling me a social butterfly, which I never would have, if you told my parents that you described me as a social butterfly when I was too scared to talk to anyone at school, that would have been quite a metamorphosis, I suppose, from some little thing. But yes, so I have my Lord's ticket for Sunday, assuming the play still carries on. But
and are there things from cricket, from that you bring to the these transferable skills that people talk about?
They do talk about it, don't they? And I would like to think that I was a team player and a team supporter, I suppose. I think that I've never been brilliant at playing sports, but I do support sport. I support the team structure. So therefore, I hope that I've got a style of leadership, for example, clinically, that would support the physiotherapists in doing what they want to do, support the plaster techs in doing what they want to do. Because if they're a happy team, then our team is better. And I think the thing about the incremental change which was brought about in the Rugby World Cup, or the hockey team, I mean, it's been brought about in almost every successful team, that if you bring about incremental changes to your performance, I don't like the words reflection particularly, but it's the word you have to use these days, isn't it? To sort of think back and see what's working and what's not working. I think good teams used to do that anyway, but now we have a name for it, and we know that we have to have a stepwise quality improvement project rather than just try what works and make it work.
Thank you.
Thank you, Prof. Eastwood. Sorry, I've just been on the phone trying to get Prof. Briggs back online. Yeah, I'm sure he'll be on.
There's a good question in the Q&A, which you'd also brought up, about whether what being in a leadership position in Europe, and that did remind me. So when I worked in the European world, if you like, it reminded me that I was one of the few people who could only speak English. So every time you met anyone, you know, everyone would be speaking a different language. I'd come to the coffee table and they'd all stop speaking their language and speak English for me, which made me feel acutely aware of the limitations of my language skills. But it also meant that when you're sending emails round, and you know, my Dutch colleagues have a certain style of email, and the Germans have a certain style of email, and the Romanians are very flowery in their email. So you just have to watch your style of language and really understand what someone's saying in their email. They're not meaning to be short and sharp and critical particularly. It's just that they have a short and sharp style of writing as they do in talking. So it's a recognition that everyone is an individual, and that we're all probably singing off the same hymn sheet, but we've just got a different intonation to the way we say the words and how the emails come across. So I've always been much warier than I was about email correspondence after my European time, just to sort of be careful how I wrote. And again, you have to keep it simple if people want to understand what you're saying.
Thank you. There's another question on the chat about coaching for consultants earlier in their career, and something more common and quicker than having to do academic degrees. Does NHS provide any?
So coaching for what? Leadership? Is that what we're talking about? Yes, I presume so, looking at the question here. You know, again, I think we are all so busy with our jobs, and we believe to be efficient and effective. You come in, you barely need to see any of your team now, because they're clerking the patients while you're doing the pre-op ward round, then you do the check, then you're busy on your emails, then you waltz into theatre, you come out of theatre. And all of that leaves less time than I would like for the support of your colleagues, and for the chatting through difficult problems, for chatting through how you might organise your clinic better. And everyone's always a little bit too rushed. So, for example, for many years with my junior colleague, who, this is giving the game away, everyone will know who I'm talking about, but we share an office together at Stanmore, and we happen to be around most, but you know, I would wait till the end of the day until he came back from theatres, just for a bit of a debrief. And did we often end up in the pub? Well, maybe we did, but the point was that we would just catch up and have a debrief of the day, but just to catch up about life in general. So now, if we can't do that, then maybe we do have to provide official courses and mentoring and coaching courses, and there are some really good ones available. I think there's a balance, isn't there, between being allocated a mentor, or an experienced consultant is allocated a junior a mentee, or do you pick a different mentee for different aspects, someone whose home life balance, work-life balance you admire and want some help with, and others who you might want help with in their managerial style. So I think it's something that we should foster and encourage within a consultant body via social events, less formal meetings, that sort of thing, as well as having online courses that you can do as well. And if you need a certificate, I understand you need a certificate these days for almost everything in life, but I don't think you need it to actually be a good leader or a good coach.
I completely agree that some people are naturally just good mentors, coaches, leaders, and you clearly are one, Prof. Eastwood. Just everything you described, you have lived experience, and you feed it back, you pay it forward, which is not necessarily the case with everyone who practices orthopedics. And I think that's perhaps why coaching programs are becoming more popular, because you can be trained to be better at feeding back, at mentoring, and these are all that popular phrase at the moment, the emotionally intelligent traits that we can improve. And in fact, I'm fortunate that at our institute at Cambridge University Hospitals, they've engaged in a program called that's headed by the Institute of Healthcare Improvement, which is a global organization, and it is about improvement coaching. So there is a huge website. You can go on it. There, maybe you can persuade your organization to go and engage in the program, and then they will be able to provide you the official training. But it is something that I agree with the question, is that it should be earlier on in our careers, because if you look at sports, I always go back to sports, but look at Novak Djokovic. He's won so many things, and yet who does he have as his coach? Is another winner, is Boris Becker, and then Goran Ivanisevic. So there's always so much we can learn from our coaches, and yes, coaching is a good thing. It doesn't have to be necessarily from our own profession, does it? It could be from...
No, and I would say maybe starting junior career, but certainly mid-stroke-later career. I think there's a lot to be said for having official links with someone outside. So I think it could just be outside surgery. Certainly, for example, chatting to Claire Marks years ago, before she took on her leadership role, she had been in touch, for example, with the leadership of the College of Accident and Emergency, the College of Pathologists, just to see what they were finding. And of course, they're all got similar sorts of challenges, really. And then chatting to people outside the field worked really well. And so I did learn then that that's the sort of thing that you shouldn't just stick with the people, because that's what friends are for, aren't they? Those people who'll just say, oh yes, Deborah, you're doing a marvelous job, you carry on. But you need someone who's prepared to be a bit critical and ask you to think differently. So
a diverse crowd.
Yes, exactly.
And
Good word.
I wonder whether,
word.
Linking everything that we've been talking about just now, I have found, I don't know whether you do this as well, but I have read a lot of elite sportsmen's or elite coaches books. So the best one I read, Phil Jackson's 11 Rings, if anyone has watched the last Dance, the actual original idea of it comes from that book, and the way he talks about team leadership, building a tribe, dealing with A-type personalities like Jordan and Kobe Bryant, the way he makes these individuals understand that you will not win unless you're a part of a team. It doesn't matter how talented you are as an individual. So I have found those books incredibly inspiring, and the way that elite sportsmen and elite coaches talk about difficulties that their athletes face or they face as coaches, I find that quite transferable sometimes to what we sometimes have to deal with in theatre or as part of a team, like you said. Yeah.
And certainly trying to deal with the type A personalities getting in the way is it's a recurring theme in our line of work. I haven't found the total answer to dealing with them all the time, really. Just let them have their say and then try and swing it around the way you want it to be. But yes, I think you're right, Pam. I think those are impressive books. And of course, they're impressive books because they're writing well, and they're communicating their point of view well in the written word. And again, that's what we need to do in our written word and in our spoken word as well.
Sunny, how are we getting on with other leader?
Still finding him. We've sent a
I'm never going to let him live this down, really.
That's brilliant, Professor Eastwood. You can keep this one. I'm conscious of the time, and if anyone needs to be going, in terms of Prof Eastwood, I know that you've been very kind to us, and well, despite being double booked, you've given us priority. The trainees priority. Thank you, Prof.
No, it's absolutely fine. I just find now that with all these Zoom meetings, I know they go automatically into my calendars, but then I sort of forget how many I've said yes to, really. So it's a bit tricky. So
that's probably a lesson that we're all learning, I think, and how not to overcommit, especially in this day and age.
Yeah, because if it used to be a BOA day, I would write that day off and I would walk all the 15 minutes from Gosh to the BOA, but I would feel that was my BOA day. But now I think it's BOA 1 till 3, so that means sort of 12 till 1 I can do this, 11 till 12 I can do that, and then you forget that they haven't got the timings right. Anyway, we survived.
So do you think you've been more productive because of COVID?
That is a very good question. I think yes and no. I think meetings like this are great, and you can achieve a lot in a Zoom meeting. But I don't think, for example, we're good enough with the Zoom meetings at saying, right, these are the action points at the end of the meeting, and we have no minutes of half, the meetings that I go to on Zoom. So I feel that's not as much progress made as when you see people face to face and you have a break and have a bit of a coffee chat. So I've got more in. I've never done so many meetings in my life, but have they been as productive? No, I'm not sure. I think the BOA has tried to do a few sort of short life working groups, which unfortunately are often in the evening, but we just say we're going to just have 5 meetings about this, and we have to deliver something for each stage of the meeting, and you're not going to carry on forever, so it's going to take up 5 hours of your evenings, but that's it. You've got to get the job, if it's doable, you've got to get the job done rather than have it drag out. But what do you lot think? It's you're the generation who are experiencing this change, so do you think you've accomplished more?
So I think I'm doing something called the Chief Resident Program with Cambridge University, which is like a mini MBA, and I do think that because some of the sessions are only half a day, so I think having to, and I live an hour and 20 minutes from where I work, I think if I've had to keep driving to attend the sessions, I would have missed out on like my morning or my afternoon clinical activity, whereas I can go into work, do the clinic, do the theatre session, and then log in the afternoon or the morning, and I can have it all someday. So, and for I'm about to go to Canada for a year, and it's been fantastic to meet my other colleagues, my future colleagues. We've had a couple of Zoom meetings, and it's been fantastic to meet them in advance. And everyone's of course very familiar with the technology. So from that side of things, it's been great.
Yeah.
And just to add to that, I think it's good to be able to catch up with everything that you may have missed as well. You don't, if you're not there live in person, there's always an opportunity afterwards to catch up and re-watch any videos and learn afterwards as well. So
do you find you do
that? It depends when the pressure's on and you need it. Yes. But particularly what I found useful is short kind of 10-minute videos that we've been having uploaded, or just before you go into say a tibial plateau or operation or something, you can watch a short video beforehand, and you can learn from that point of view and remember the key steps. And also it makes making notes easier as well. If it's short videos, it makes you can make just 3 or 4 bullet points on each video, and just I keep notes for every operation from that point of view, and I found that very useful.
But I mean, the explosion of sort of online teaching and webinars, that's surely got to be like all new technology. It will reach a peak and then settle down, or do you think there's no end to that, Neil?
I think
I'm turning the tables here. I'm doing all the asking now.
This is why we chose you as a great example of a leader. So yes, there has been it's viral, hasn't it? It's gone viral. Yeah. Thanks to Ortho Hub.
Yes, I agree.
Facilitating this for us. But education, two of our presenters were talking about education. That's all we need, good old education. But how can you democratize that education? And it's through being enabled with the technology. And so suddenly there was a last year provided that catalyst for harnessing something that's always been there. We've always had Skype, we've always had WebEx, and yet we haven't harnessed it. And now we've got YouTube channels. I know that my colleagues at Addenbrooke's, who are awesome educationalists, but no one else necessarily knew about it. But now they've got their own Cambridge Orthopedics YouTube channel. They're able to demonstrate what we can do. But we realized that you still need that practical element and the face-to-face to supplement it and put it into together. And then there can be too much. And so we do try and limit the amount of time that we spend on the screen. So we do try and have regular breaks and make sure that it's only a half day and not a full day, which was perhaps a bit different from previously. And in fact, even the exams have gone fully online as well, almost. Interviews, Pam told us how she secured her fellowship. It's all online. So all these things are being facilitated by technology, and we've got to embrace it and just maximize it, optimize it. Talking of which, I think it's coming up to 5 o'clock, so I don't know if Sunny, we've tried, haven't we, with Prof. Briggs?
Yeah, thank you. Sorry about the technical difficulties today. But thank you very much, Prof. Eastwood, for having
it right first time, Sunny. He should have just got it right first time. I'll tell him
that. Thank you very much for agreeing to be interviewed. It's been very educational, very useful for all of us. We'd like to say thank you to...
He's calling in. I reckon, how much should we bet that he was in another meeting as well?
I'd just like to thank Ms. Lucy Dennell, who's not here as well, and Professor Briggs in his absence, Mr. Loeffler as well. Thank you, Mr. Kang and Mike Barrett as well for their guidance in setting up the series. Thank you, Pam, Chloe, Albert, Carla for doing all the behind the scenes work as well. Next week we're going to kick off at the same time. We're going to look forward to another set of amazing lectures. An interactive series looking at the evolution of leadership and conflict resolution as well.
Hello, Professor Briggs is back.
Welcome back, Professor Briggs.
Sorry, I'm on the telephone. It's been a nightmare.
But you were persistent. You get the job.
I am very persistent and resilient.
Suni, shall we do it? Shall we do it? Let's do it.
Do it.
Prof. Briggs, over time, you've been incredibly successful at driving change. What lessons have you learned about driving change that you think could be useful for us trainees?
Okay, that's a very good question. The first thing I'd say is one of the reasons I've been able to drive the change is my experience. So when I became a consultant at Stanmore, I set myself milestones at a cost of time of about 5 years. So the first thing I wanted to do was build up a good reputation in terms of my practice, which I think I achieved. I then wanted to make sure that I was to get involved in hospital management. So I became medical director, as well as having a full-time practice. I was medical director for 15 years. I was also a TPD, and that gave me the insight in, I think, what was needed when the time came. And it was really you then need the opportunity. And the opportunity was the financial crash of 2008-9, when there was no money left in the health service. And from the experience that I had as a clinician in a tertiary referral centre, that if we'd done things differently for patients or made a different decision, then their outcome would have been better. And so I then came up with the idea of the GIRF program, and it was difficult to push it through. But once we got going, we got 12 sets of data, visited all hospitals, and have seen significant change. So it was resilience and keep pushing to get that recognised, and then the rest has been as a result of that, as people have seen the success of the GIRF program in orthopaedics, really.
And there's a very impressive website with lots of documents to download, but is there any particular case study that has stuck with you and of best practice that you've been able to achieve as a result of GIRF? And could you tell us about it and what you've learned from it?
Yeah, so I used a slide earlier on today about United Lincolnshire. Okay, that is a trust which had 4 sites. Morale was terrible, actually, amongst the clinicians. Outcomes were not good. They'd cancelled 1,300 patients. They'd cancelled 1,300 joint replacements in a year on 900 patients. So they cancelled some 2 or 3 times, and they were at their wits' end, to be honest. So I was asked to go there and suggest how they should do things differently. So we highlighted a green site at Grantham, which meant staff and patients had to travel, but it meant patients got a really good service. And the outcomes 2 years later was much better outcomes, low litigation, length of stay, which was now exempt, about 2.4 days. They were doing 5 joints on all-day list, and morale was an all-time high amongst both the surgeons and the nursing staff, physios, OTs, and theatre staff, because they were doing the job they wanted. And there was not a single complaint from a patient. They were just delighted to get their operation, and they cleared their backlog in that time. So it was very heartening to see that and to see the change, so much so that before we came into COVID, the urologists and gynecologists were going to do something very similar. So what I learned was it's showing what can be achieved, taking the clinical staff with you, suggesting change which sometimes can be radical, but making sure you deliver on that. And for me, that was just fantastic. So that worked really well.
And you talked about low morale there. One of the things that struck me from the GIRF report was how you talk about people who are clinicians that get disenfranchised. How do you get them to engage again in order to get the change delivered?
So I think the key is that we're all surgeons. We like operating. We like doing things well. It's showing data that can then implement positive change in a trust, which we've achieved quite a lot. And once you do that, and clinicians, whether you be nursing staff, theatre staff, physio, OT, and importantly surgeons, getting back to doing the day job, your patients come in, they're not cancelled on the day, you have your ring fence beds, you have your theatre time, morale rapidly recovers, I have to say, and you can re-energise the clinical staff. And that's what we found. What we will not achieve is, unless we use that same format, we will not win. And it's just showing the leadership really about what can be achieved. And remember, it's all about the patients. And we're all trained by the NHS. We're all trained by the taxpayer. We are valued by patients. There's no doubt about that. And we owe it to them to give a good service. But we've got to have the methodology in which to do it. And so I've tried to re-energise the relationship between clinicians and managers, say working shoulder to shoulder, which said by the last trainee on the call. And if we do that properly, we can succeed. And we need to do that even more so now with the long waiting list we've got post-COVID, because we're all going to have to work very hard together to deliver what we need to do for patients.
Thank you, Prof. Briggs. You mentioned working shoulder to shoulder. What would you say is the biggest barrier to effective communication between managers and clinicians?
Well, that's really interesting. So I think that we have, for a number of years, I think we've lost that relationship between clinicians and managers. Our voice wasn't heard, I have to say. I think it was different at RNOH, where I was the medical director. I was quite a strong voice at the RNOH about setting standards, outcomes, etc. I think in many places we lost that. We lost the voice, and surgeons felt they weren't being listened to. Well, I think people realise now that unless we step up to the plate here, we're never going to resolve the big issues that we've got with us now. And I think there is an opportunity for an absolute new beginning and resetting the relationship. That's what I've done in London. I've led the transformation of the surgical services in London with the support of the regional director and the regional medical director. It's worked well. Clinicians have really signed up to it. We developed 29 pathways for 6 surgical specialties. We did that in 7 weeks. If you said to me pre-COVID, how long would that taken? I'd say you'd do 1 pathway per year. I've done 29 in 29 years. So the clinicians are there. They want to be heard. They want to help. And it's all about resetting that relationship, which I think we've got a real opportunity to do now. And I hope that we can set up this system so that when you become consultants, and some of you are almost there, that the relationship has changed significantly. And that's what I'm trying to do.
Thank you. We asked Prof. Eastwood this earlier as well. Do you have a particular leadership style, and what are the advantages and disadvantages that come with?
I hope that I can be brusque at times, but I hope that my leadership, so I talk the talk and walk the walk, I believe, with my clinical practice. I think I had a good reputation in my clinical practice, and using data and conversations, the data usually speaks for itself. And that's the beauty about the GIRF program and the 40 specialties we've done. We've had fantastic clinical leaders. And I was very lucky when I started the program, because I was then president of the British Orthopaedic Association in 2013-14. And that gave me a real mandate to drive change. And what was really interesting, because I visited every hospital in England during that time to do the GIRF work, the number of clinicians said to me, I was the first president of the BOA to ever visit their hospital. So I was already starting on the front foot when I arrived there. But sometimes you have to have difficult conversations with some of the low volume surgeons, with some of the outcomes, with some of the litigation. But the data says it all, especially when it compares their trust to other trusts around the country. The data really does say it all. So I think I lead from the front, always have, and I think people respond, and people tend to follow and support me in this. So I'm very lucky with that. If you said to me what the disadvantage is, I think it can hack people off at the centre of the NHS. It's being told really in a direct way what we need to do and what's not working. But I think now there's a realisation that without real clinical leadership and clinical drive, we're in deep trouble. So I'm getting a lot of support from the centre now.
Can I just barge in there, Tim? Because I think that this last year has shown what clinical leadership can do, don't you think?
Yeah, and I think the BOA, and thanks to remind me that, the BOA has been brilliant throughout all this. Right from when I started the GIRF programme, right till now, I think the orthopaedic fraternity and the BOA should be very proud of what they've done. We're all the orthopaedics have led a lot of this change across over the last few years, and really have set the benchmark for others to follow. And people now recognise that and have wanted to get on board on what was initially an orthopaedic program. So the BOA and the orthopaedic community should be very proud of that.
I set that up well, didn't I?
Well, I have to say, Deborah, it was a privilege to be president of the BOA. Yeah. It was a privilege to be part of the BOA, and you've got a organisation there, an association that is absolutely thriving. And again, it's maintaining that, keeping it going, and the leadership they've shown over the last few years has been extraordinary, very positive. And Deborah didn't set that up.
And that's what we should all vote and get involved, right, Prof. Eastwood? should
Yeah.
all be involved.
I do think you should all be involved. A little bit more wouldn't go amiss.
Prof Briggs, for the
And tell us
trainees,
what
for the trainees, Prof Briggs, you almost described a personal development plan. Now, was that something that you consciously done, or is
No.
that something in retrospect that you would?
No, I mean, retrospectively, it's worked out like that. But prospectively, I never planned it that way. And remember, right, I only came up with the idea of GIRFT in 2010. So it was just fortuitous that idea came to me. It's a simple idea. I'm an orthopedic surgeon, but it's a lot of common sense, and actually, it works. And no, I think the key is we're all leaders in some part, and I think it's, first of all, get your skills up so you have the respect of your colleague. And then I would agree with Deborah, get involved in either teaching, training, or your association, because the association is only as good as the people that follow on from me, follow on from Deborah, follow on from John Skinner, etc. And at the moment, the BOA is thriving. So I think it's a real great time to get involved. And as trainees, I've always been impressed with BOTA. So get involved with BOTA. I think that's really important. But, you know, set your skills up and get out there and let's help. You know, it's easy to do a minimum, enjoy work-life balance, which I've never had. But I think there's a real opportunity now to get involved and help as we recover the situation from where we're coming from.
And for those trainees that do want to get involved, are there any opportunities within GIRFT, BOA, to either professor?
Well, so I'll talk about GIRFT and then I'll hand over to Deborah. Definitely in GIRFT, I had a meeting set up last week with 14 medical students. They wanted to meet me and talk through things. 4 of them come through and said, can they help? Yeah, absolutely. We've got lots of things we've done. We've just had 2 papers published in The Lancet, 1 in Nature Communications, something I would thought would never be possible for an orthopedic surgeon, but there you have it. They're published because we've done a huge amount on the COVID. So there is a huge amount that we can do together. Yeah, I'd love some help. The more the merrier. We're looking for some fellows, actually. And if people want to come and help, we'd be more than happy to have you.
Yes, I think I'd, of course, echo everything you've said, Tim, about engagement and involvement and the clinical leadership program, the future leadership program. Quite a few people are involved with GIRFT projects. They're also involved with SAC type projects and selection panel projects. So I think there's a lot of scope. And, you know, I think if anyone's got a good idea, like some of these quality improvements, you should pitch it to the BOA, because I think we should be open to all sorts of ideas, or pitch it to the Transient Journal and see how you can get people involved. So yeah, we're open. I
totally agree, Deborah.
I want to broaden our membership in terms of our voting membership, and that started last year. And I can't promise anything, can I? But we will work towards a broader involvement in the BOA.
So that's really some really good points about the Future Leaders program, and I think that's only open to the post CCT trainees. Is that correct?
I think you're right, Neil. I should know, shouldn't I? I should have done my homework, but I don't.
So so I think that's right, Neil. But there's the Medical Directors Fellowship Program, and I've got 2 fellows through that at the moment. One of whom is ST7, the other is ST4, and they are really, really exciting for the younger members to take a year out and do something like this. The trouble is that they find it difficult going back to doing the day job, because in their year they get into meetings with all the great and good of the NHS, and then they go back to being a trainee again, and I think some of them find that difficult.
Thank you for that great insight. But hopefully for the attendees and people watching this in the future, they will see that there are opportunities to pursue and engage with improvement programs and quality improvement projects on a national level. Thank you.
Perfect.
Thank you, Prof. Briggs, for joining us via telephone. Were there any other questions from participants?
Sorry, there was. Sorry, Professor Briggs. One of the themes of today was, as you heard, day case arthroplasty, and there's a question from the attendees. What's your view on it?
I think it's got a great future. If you go to Halifax and Calderdale, I think it's 60% of their knee replacements, either half or total, are now done as day case. And they mobilize the patients early. They get them to bend to 90 degrees straight after surgery. They go home within 23 hours, and their results appear to be very, very good. Oxford are doing more. Up in Scotland with their Dunstan, they've done quite a lot of day case arthroplasty of the hip. I was always concerned with knee replacement, what would happen at 2 in the morning when the patient's got a lot of pain, but they seem to have worked that out. They seem to be working very well, their anaesthetists. And absolutely right. If you go to the USA, you're in hospital for about 36, 38 hours. And there's no doubt we can drive towards that. So I think it's quite exciting.
Okay. You need a fellow for that. Day case arthroplasty fellow.
Does someone want to come and work with us, do they?
To go and prescribe the paracetamol in the patient's own home or something like that.
Perfect.
Thank you very much.
Thank you. Thank you to all the panelists again for attending and for teaching us such valuable lessons. What we'll be doing next week is conflict resolution and expert leadership. So we look forward to seeing you then. So it'll be 2 o'clock next week, Wednesday, June. And we'll see you then. Thank you again to Prof. Eastwood, Prof. Briggs, Mr. Kang.
And congratulations to Roshana and all the presenters.